Assalamu alaikum. So, sorry, my internet was not working. So, late. I hope you all are fine. You are preparing well. How many days left from exam? 7 days. So today, I hope it would be my last session. So you may do the self-study. Okay. Uh, till next 4 days, 5 days, you must do the self-study, and then we will have a 3 to 4 days session, 3 day session, and one day we will have a mock exam. Okay. The mock I ask you that we will have with after this that would be covered in grand mock. Okay, that would be of 180 MCQs, 90 in each file. So you have to do this mock in 2 hours and 2 hours, 4 hours. Okay, so that what I have planned. So 31st, 1, 2, 3, you will do the self study. Okay, and 5, 6, 7, we will have a session, fast revision session, 4, 5, 6. Okay, and on 7 you will have a mock. 8, 9, 10 you can do the self study. I think you will agree with that, because before attending the fast revision session, I want that you all may go through the syllabus, you all may know the things. So if you know the things, and when I will be revising, that would easy to memorize. Timing I will confirm tomorrow because my rota will be updated tomorrow. So 4 to 6. 4 to 6. And 7 maybe one session. 7 it depends, but 7 mock will be on. So today we will have a quick overview of PEDS emergency, the things which are left, and that is not covered in the SLO one. I will cover that one. Yeah, 4, 5, 6. 4, 5, 6. Detail. Okay, these are the notes. Okay, first is the limping child. I have shared algorithm for the limping child from the RCAM learning. Who have gone through it? Yes, good, excellent. So, limping child, first of all, you will see that patient is having any history of trauma, okay, or the age is more than 9 years, and possible there is Sophie. Then you will give the analgesia, X-ray, okay, that what if there is a history of trauma, age is more than 9 years, child is limping, possible supraperthes, then we will give the analgesia. First, we have to make the patient painfully. Then we will do the X-ray, and that what the algorithm is. Okay, so we will see if the X-ray is normal, no history of trauma. Okay, if X-ray is normal, if X-ray is normal anything, then we will treat accordingly. If X-ray is normal and no history of trauma, then we will see some sign and symptom. We will take the history if patient is having fevers, any stomach symptoms. Okay, uh, if capillary fill time, tachycardia, tachypneic, poor feeding. So though we will rule out other systemic illnesses that can cause that have caused the patient to become a limping child. If any maneuver is present, we will send the lab like full blood count, CRP, blood culture, uh, and that what we can also do the if child is age is not more than 9, no history of trauma, no, you're not suspecting the Sufi, then we will also follow these things. Okay, we will take the history, fever, any other symptom, joint pain, swelling, any like these symptoms are present, tachycardic, tachypneic, uh, urinary symptoms, so we will send the lab. If anything is uh, present in the labs, anything, then we will refer to the peds and joint care. If child is not unwell, then we will see that pain is localized to hip. If that is not localized to hip, then we will do the complete examination for rule out any pathological thing that is causing the limping child to become a limp, to walk like a limping child. So if there is any pain localized to hip, then again we will can go for the ultrasound, X-ray, full blood count investigation. That what we will do on the ultrasound. If there is any effusion, an infective process like fever, inability to weight bear, ESR more than 40 mm, WBC more than 12, that mean what the child is having. That's called the Kocher's criteria. Okay, so we will read about it. So then we will refer to the orthopedic. If there is nothing available, effusion present, then we will discharge the patient with analgesia. So, and we will also give the advice to return if symptom worsen or fever develops. So, ask to follow up in the ED clinic. So that should be the. So whenever you see any MCQs, anything, then you should follow these algorithm, these things that will give you a good clue. Okay, limping child, there can be infective causes. Okay, so what can be the infective causes? Osteomyelitis. Okay, so that is the infection of the bone. What investigation you will do? So same that it depends on the age, causes, fever, sign and symptoms. We will send the full blood count, CRP, blood culture. That should be our plan. So if there is osteomyelitis, we will give the antibiotics. Septic arthritis, that's a different thing. In this patient, patient will be unable to weight the bear, fever, there will be inflammation, and patient will be in sepsis symptoms. Patient will not look, child will not look well. So that's we will also do the workup, uh, complete blood count, full complete blood count, CRP, ESR, cultures, ultrasound to look for an infusion. So that's what if there's an infusion that needs drainage, IV antibiotics, that's what we are going to do. Okay, so most of the time in the MCQs, that how will you differentiate between osteomyelitis and transient synovitis? That's very important. Okay. So although you can differentiate between transient synovitis and septic arthritis, that how? from the coaches criteria. But most of the time in the exam, that how will you get a clue between the osteomyelitis, and between the transient synovitis. So always remember, transient synovitis, there will be prodromal upper respiratory tract infection or any viral illness that they will give a history, and age will be between 3 and 6 years. That's very important to remember. So that is inflammatory disease of the hip. Okay. And before that, they will be given history that patient will have this symptom, flu-like symptom, anything, and age will be between 3 to 6, these two things. And the other that will be related to if on examination, anything there will be pain. So that's how you will. In transit synovitis, child will be afebrile. Okay. So that's also very important, and we will give the NSAIDs. That's what. But on the ultrasound, they will be given effusion. That's 2 to 3 things that you must remember in the exam they can give. Okay, septic arthritis, that you must remember from that coaches criteria, that is walk few. Okay, walk few. Walk mean few mean unable to walk. F mean fever, E mean ESR, and W mean WBC. Okay, so their WBC more than 100, ESR more than that, inability to walk. So if nothing is present, they are least likely. One is present, that 3%. That means two predictors are present, that is 40% chances that it is a septic arthritis. 93%. So percentage is not important, but two factors that will tell us that it is the most likely septic arthritis. Okay, pyocyanomitis, but that's also after the any symptom, and there can be the minor trauma. So in this cause, muscles are affected. Myositis. So that is myo mean muscle, cytis infection. So that's you must remember. We will give the hydration and supportive therapy. So that's not. But Perthes disease, that also called the Ledkov-Perthes. That is the cause is the idiopathic. That can be the Perthes disease is the avascular necrosis. You can see on the which side you are seeing the avascular necrosis. So you are going for exam. You may tell this. Yeah. Okay. Good. So on left side you are seeing Perthes disease. So that's the common question in the exam. Okay. In the exam, they will age. You must remember that will be 3 to 12 years. Causes so you must remember everything in the exam. They will not ask what is the diagnosis, so they can give confusing options like it occurs in this age, what is the cause. Okay, and like patient will have a limited rotation to external, limitation to external rotation, limitation to internal rotation, abduction of the hip. So you must remember these things in the exam. Most of the time, I told you that 40% question will be simple, like diagnosis, management. You will know all these things. 30% that will be intermediate. 30% will be very difficult. Okay, so you must be ready for anything in the exam. So limitation to internal rotation and abduction of the hip. That's very important. These clinical features should be remembered, that child will be having a limitation to internal rotation and abduction of the hip. Investigation frog leg lateral view we will do, and that will reveal the widening of the joint space, decrease in size of femoral head there because of the avascular necrosis. So all these things you must remember, and complication that can osteoarthritis, chronic pain. So you can see on the left side, and there is also the widening of the joint space. You can see the widening of the joint space. Then is the slip upper femoral epiphysis. That mean that will occur when something slip over. If you have placed something like that and piling up something, when you place anything heavy on it, these are not heavy. So what will happen? They fall down or they slip down. Like that happen in something, whatever you are doing. So that will also happen, slipped upper femoral epiphysis, that will happen in overweight children. So that's also in the exam, that will be a clue, obese children, child, and age will be between 10 to 15 years, okay? And child is abused, but their her bones are not accepting the weight or not bearing the weight. So that can be, but there can be endocrine pathology. So displacement of femoral epiphysis from the metaphysis. So that you must remember what is the uh, reason and how to pick the MCQs. Severe pain, externally rotated leg. That also you must remember. With severe pain, externally rotated leg. Okay. So, and there will be shortening of the affected limb. So these things you must remember. Same, we will do the AP or frog leg lateral view. So that will reveal the displacement. The other thing that is Tree-Thoman sign in it. Okay. Tree-Thoman sign. So Tree-Thoman sign we discussed in the quiz 2. That is a line of Klein that passes the above the femur. Instead of that should be intersecting the femoral epiphysis in the normal hip. Where is the X-ray? So it will cross above the head. So that's what we will do the urgent evaluation. So we will on which side you can see. Okay, so that's Tree-Thoman sign that will call. Uh, so in the exam, most of the time that what the sign you will find in this X-ray. So you will not most of the time in exam tension and that you will pick the Klein sign or there will be a confusing Klein sign, Tree-Thoman sign. Both always remember sign name is Tree-Thoman, but this is a clean line that we also draw in the normal hip and that will be above the exercise. So total fracture, that is the spell fracture of the tibia. So that can occur with twisting motion when falling. So that will occur in 1 to 3 years. So these ages are also very important and that will happen in distal 1/3 of the tibia. Initial X-ray can be normal, so you can repeat it. Redness, bruising on the affected area, match with the above and below knees back slab. That's common in the toddlers. That's why it's called the toddle fracture. Here you can see. Okay. So then is the Osgood-Schlatter disease. So that is the epiphysitis of the tibial tubercle. So that is also from the stress, overuse, that same age like Sufi, 10 to 15 years of age. So that will it in for the related disease, they will give a scenario that child was playing like that, skating, running, or like climbing. So that after that that happened, that's also very important. So either child was having these symptoms, and when child went for playing or like that, then it become worsened. So that's will be in the history, you must remember. Tenderness of the interior aspect of the knee, tubal tuberosity, running, kneeling, skating, that will aggravate it. So most of the time you will not need the X-ray. So it is self-limited. You must counsel the parents that it is self-limited. So with the rest, symptom will respond. So that the X-ray you can see. Next is the severe disease that is called calcaneal epiphysitis. So that is the inflammation of the growth plate in the calcaneus. That's not the X common thing that have been previously asked, but you must know about it. You can see the calcaneum. So obviously that's the difference from the above part, lower part. That's how you will differentiate it. Okay. That's the inflammation of the growth plate. Then is the Salter-Harris classification. That's also very important. So what's the formula you remember? Salter-Harris. Yeah, from SALT. So what mean the S? Separation. A mean above. L mean lower. And E mean Salter. T mean through. Okay. So that's how you must remember. That's most of the time they will give these type 2, 3, and 4. Okay, they will not give the type 1 and type 4. Always remember that can be the confusing. It's very difficult to differentiate that it's the separation or the other thing. Okay, so epiphysis separated from metaphysis, fracture plane passes all the way through the growth plate. So that's the type 1. So in this their fracture line that will extend from the physis to metaphysis, that will not involve the growth plate. In this, that will be physis to epiphysis below, but that not involve the physis. But in type 4, that will involve all of the growth plate, metaphysis, growth plate, and down through the epiphysis. So through, and that is crushing injury to the physis. So most of the time they will give type 2, type 3, and type 4. Here you can see on the X-ray. So you can see that it's very difficult to assess. Okay, so that's the radiologist type and Salter as type 1, but on here you can see very easily, you can see that it is above. Okay, and then here you can see that it is below the growth plate, and type 4 you can see it have crossed all of it. So in the previous exam and in the exam, they will give most likely 2, 4. Osteosarcoma. So what the formula I have told to remember? Geomed. Good. So you must remember the geomed. Geomed. Okay. So G means giant cell. Giant cell carcinoma that will occur in the epiphysis. O mean osteosarcoma that will occur in the metaphysis. E mean Ewing sarcoma that will occur in the diaphysis. Okay. Other thing that you must remember the features on the X-ray. So what will happen in G? What type of feature you will find? So you may revise. I am asking. That's why. Who is iPhone? So you may join with your name. Okay. I may know that who is joining iPhone. Please join with your name. I don't know. You are joining from last 3 to 4 session. Okay. Yeah. So you will take the soap. Okay. So you will take the soap. So in the giant cell, there will be soap bubble appearance. Okay. And you will take the soap in the sun. That is an osteomyelitis, that will be sunburst appearance. Okay. Sunburst appearance. So what will happen? It will soap will open like onion peel. Okay. So that's how you must remember. And the other thing is age. So that's how you can also remember the age with geomed. That is less than 20 years, and then 15 years. Next is, I think, more than 20 years in this osteo is less than Ewing. Where the giant cell? Giant cell is 20 to 40 years. Read it from these notes. So less than 20 years, secondary predictive factors such as Paget disease, bone fog, familial retinoblastoma, metaphysis of the long bones, often in the knee region. You must remember. Also, you must remember knee region. Okay, it will hurt mostly in the, but all of these they can painful enlarging mass, pathology of fracture, sunburst pattern. We discussed surgery and chemotherapy. That's the management plan. You will refer the patient. That's how you can see the sunburst, but you must go through the Google. Okay, here I can see osteosarcoma X-ray. Okay, so you must go through like this, find the images and see all the images which are given. So you may recognize in the exam. It will be very difficult for you to recognize. That will be not images that you have seen. Okay, so you can see different type of osteosarcomas. So that's you must go. I think this X-ray came in the exam. Most of the time they give X-ray from Google or Radiopedia. Okay, so Radiopedia, that's very important. So all the X-ray you must go through Google when you are studying. At that time, only that time when you are studying, go through the Google and search it. X-ray, just write X-ray. You see all the X-ray, then search X-ray Radiopedia. So that's how you can see. That's clear one. But in the exam, you will not find the clear one. So that's also you can see different one. So all type of X-ray you must know. As you know, in when you are studying the ECG, so The ECG you see in the books, that's different, but the ECG you see in real life, that's different. Okay. So you must go through it. Ewing sarcoma, most common in white patient, generally the male less than that. Age is also important. Diaphysis of the long bone, pelvic flat, especially the femur. So that was the knee joint. X-ray revealed defined lytic lesion of the femoral diaphysis. So we will refer to the orthopedic. That is the giant cell. You will see the aggressive benign tumor, neoplastic cell that express wrinkle. These all things you must remember. Okay. Reactive multinucleated giant cell, osteoclastoma, this is also called. Probable appearance on X-ray, radiotherapy, and chemotherapy. That's the so you must go through Ewing sarcoma X-ray. Where are the so you can see every X-ray is different, so you must go through it. Now you will search radio. Oh, that's different. I think Ewing sarcoma. So you can see different type of X-ray. So there are some CT scan. Don't go through that like this. So Ewing sarcoma. So that's how you must. Okay, next is the probable appearance. That will be in a giant cell tumor, epiphysis. Okay, so that's very easy. You can see there the aggressive benign tumor, neoplastic nucleus cells, so osteoclastoma. It's also called. So we will refer the patient. Then is the Hirschenberg-Brunks disease that will occur in children. Failure of passage of meconium within the first 48 hours, repeated vomiting. So in there will be a history of delayed passage of meconium. So if the Hirschberg disease, that will not pass meconium within 36 hours. So it can be associated with Down syndrome, any genetical disease. So that's you must remember. It complication can be enterocolitis, but most of the time question that comes, there will be a bloody diarrhea, vomiting. So we will manage in the emergency department. We will rehydrate. We will pass the NG. We will keep the patient NPO. That's what we can. We will refer the patient. Okay. But the most of the time in the exam, that will be necrotizing enterocolitis. Okay. And that can be pyloric stenosis. So these are the common question. Okay. Other than the Paschenberg disease, necrotizing enterocolitis, that's very important. So that's all the gastrointestinal emergency and neonates. So that's the risk factor is low birth weight and prematurity. That's also you must remember the risk factor in the exam. They can give the diagnosis in the question, and they can ask different option. Prematurity is the risk factor. It's not a risk factor. Low birth weight is not a risk factor. So that's how they can which option is the best option. So they can give the clinical features: blood mucus stool, bilious vomiting, abdominal mass ascites. That's not common most of the time. They will be blood mucus stool, bilious vomiting. So apnea, respiratory distress, temperature. So management same, we will do the conservative management. We will pass the NG tube, keep the patient NPO, start the IV fluids. So we can start the antibiotics, okay, and we will refer to the pediatric department. Other thing that okay, next is the pyloric stenosis. That's also common. Age is very important, 3 to 6 weeks. All infant, okay, and they'll all issued mouth. They will not give that like a symptom that you can easily diagnose. Okay, they will give a scenario that age is this 3 to 6 week old. Yeah, they can give 1 month old. So that you also must remember. Okay, 1 month old, 2 month old, 1 month. Most of the time they will give 1 month old child, or they will give a scenario of 4 week, 4 week or 1 month. That would be a scenario, and they will give the history that child is not eating and mother is came with tension and brought to the emergency department. The child is not eating, losing weight. Child is not taking the feed. So that's on the history they will be given decreased wet nappies. Okay, so that will be dehydrated. So that's how the scenario will be given. And also that's the also necrotizing enterocolitis. That's also the most common question in previous history. They will be given prematurity, low birth weight, coming with the abdominal distension. So that will be given vomiting and bloody stool. These two things will be given in the scenario. But pyloric stenosis, I told you age. So you will see they will be given the ABG, the labs. You will see they will be hypokalemia, metabolic alkalosis. That's very important to remember. We'll do the ultrasound that will show the pyloric channel length more than 17, pyloric mass thickness that more than management. So that we will manage conservatively IV fluid, electrolyte replacement, and then we will refer. Most definitive treatment is pleromyotomy. Then is the interception. That's also the common question. Interception, pyloric stenosis, and necrotizing enterocolitis. So these three are the common, and that have been asked. Interception have been asked many times. In this, they will give a bloody stool. Okay, so you will confuse it with the necrotizing enterocolitis. So always remember, this is babies or toddler. Okay, so there will be a typical symptom that will be given. Child is withdrawing the legs. Okay, drying up their legs, screaming, or the child is crying. That will be, and vomiting or bloody stool. These two things will be given, not all of the three. Okay, so you must remember age will be 3 to 18 months. After a while, there will be prodromal viral illness. In the enterocolitis, that will occur in the neonates. Okay, so that's when child is a neonate, when is infant. What's the difference? Yeah, up to 28 days neonate, 7 days early neonate, and then after 7 days late neonate. Okay, so that's the classification. So you can see in the necrotizing that child will be neonate. Okay, less than 1 month. In this interception, these are babies and toddlers. Okay, so that's how 3 to 18 months. That's also you will differentiate from the age. Okay, because in the exam you will be confused that is it entero, so that most likely they will give the antiseptic. Crying, child will be crying, bloody diarrhea. So they will not give red current jelly stool. They will give a bloody diarrhea, but mother will not. Mother will tell you that child is having a blood and stools. So that's how you must remember. Age, vomiting, bloody stools. Either they will give the bloody stools, vomiting, and then the main crying. Okay, screaming. So that's how think bloody. Investigation, we will do the abdominal X-ray, ultrasound, contrast enema. That will not change, but we will manage conservatively NG tube, IV fluids, then we will refer to the pediatric department, pediatric surgery department. So then is the neonatal sepsis. So early onset, most common is the cocci and E. coli. Late onset, that is Staph aureus and coagulase negative step. So I will tell you that what you must remember in it. So red flags, that's are very important to remember. Okay. So red flags, risk factor, that are red flags. Suspected confirmed infection in the baby in case of multiple pregnancy, that is the red flag in the risk factor. Clinical indicator red flag, child is apneic, seizures, cardiopulmonary saturation, signs of shock. So these are the red flags. Other features, altered behavior, feeding difficulties, abnormal heart rate. So you must remember the red flag, that is shock, apnea, mechanical ventilation. These are the other thing. So we will follow the sepsis. Okay. Sepsis protocol. We will give the high flow oxygen, fluids, antibiotic within first hour. You must give if you are suspecting the sepsis, and then you will send the lactate level, all the investigation for other than the blood culture. That's very important. Okay, so you can also perform the LP to obtain the CSF before and after before starting the antibiotic. If there are signs of meningitis. Early near sepsis, you can give the benzyl penicillin, gentamicin. Okay, that's the antibiotic we can give. Late onset of sepsis, high risk, that's the same. High risk, there's a multiple birth, other child is having same symptoms. Respiratory distress, 16 breaths per minute, grunting. So in the exam, that red flag will be grunting. Okay, so that's you must remember that the grunting, apnea, oxygen saturation less than 90%. These two will be red flag will be given in the exam. So that's you must remember. Other they can give the motile, actually cyanosis, but most of the time they will give these two symptoms. Grunting. Grunting will be a typical symptom that you have to take. First dose of antibiotic, and that's same LP if you are suspecting meningitis. So we can give the IV ceftriaxone. Okay, that's what we give ceftriaxone, but here it's written more than 40 weeks. Gestational age we can give for neonate, but Most of the time we don't give the ceftriaxone, we give the ceftriaxone. Okay, always remember in ampicillin, we will start the ampicillin to cover the Listeria monocytogenes. In the old patient, more than I think you have discussed this in the neurology. Okay, so more than 55 years old ages, there is a chances of Listeria monocytogenes, and less than 3 months, there are chances of Listeria monocytogenes. Then we will start the ampicillin. That's very important to remember. When we will stop the antibiotics after 48 hours if the blood cultures are negative and clinical condition is improving, then we will stop it. Either we will give the, that's in the neurology, my notes I have written. So you can see for which infection we will give for how many days antibiotics. Okay. So that's for the meningitis, IV amoxicillin, ceftriaxone. Still the pathogen is unknown. If there is sensitivity game, then we can start according to the sensitivity. If positive for B streptococcus, we will give the benzyl penicillin, listeria, same amoxicillin and gentamicin. So that's what conjunctivitis. I think you have discussed it in the ophthalmology that you must not remember about it. So that's the thing that you must remember. The red flag, that's are important. Okay, only remember the red flags, and you, I know you are confusing most of them. How much you must remember? So in red flags, remember grunting. Okay, tachypnea and respiratory. So tachypnic, like 16 breaths, more than 16 breaths, more to severe chest, reduced skin turgor, and temperature is more than 38. So in the children, they will give the grunting symptom that will be a red flag or tachypnea more than 16 breaths per minute. So that you must remember. So that is for the age under 5 years. Okay. And the adult, I will tell you the what are the red flags you must remember. They can give in the exam. So meningococcal disease, that you have all discussed in the, so this table. Meningococcal disease, non-blanching rash, every time. That's meningococcal septicemia, bacterial meningitis, neck stiffness, branching rally, herpes simplex, focal neurological diphtheria, decreased level of septic arthritis that we discussed, not using extremity, not between swelling of the limb. So pneumonia, tachypnea, crackles in the chest, nasal flaring, chest indrawing, that's very important. Oxygen ratio, decreased oxygen saturation, urinary tract infection, vomiting, poor feeding, lethargy. So Kawasaki disease, fever more than 5 days, that you must remember. Okay. Other thing that would be conjunctival symptoms, hemorrhages, strawberry tongue, but they will not give all the things. They are most that will be fever more than 5 days. There it is. Okay, here it is. Okay, so I told about the children who are less than 5 years. You must remember tachypneic, less than more than 60 and grunting. Okay, so that, but in the other children, the most diagnostic for the red flag would be So alter behavior, pale and mottled, and the urine output will be decreased. Okay, so that's what you must remember. Okay, urine output, non-blanching rash, cyanosis, and the urine output will be decreased. An adult, that will be an adult. Adult. In the adult, most of the time they will give that respiratory rate and the oxygen saturation demand has increased more than 40%. So that will be a red. You must remember in the scenario that will be given for sepsis. Okay, so if they ask about the red. Okay, so okay, next is the congenital diaphragmatic hernia. So child will be presenting with the CISA respiratory distress, okay, and that unable to eat, unable to feed, respiratory distress. So we will refer to the pediatric. So here you can see the contents, abdominal contents in the lungs. So that's typical, and also you must go through testicle torian. I think we have discussed this testicle torian. Yeah, in the urology we have discussed it, and I have also discussed in this. So I told you about the which score I told you about. TOACS score, okay, TOACS score that told you, and the sign you will differentiate from the other orchitis. That's also you must remember. So that's the what blue dot sign you can see. That's what called prime sign. Yeah, prime sign. If it is pain relief, then it's not a testicle torian. Okay, that the other thing. Blue dot sign. That's also very important. That have been given many times. That in the exam that will not a clear picture like this. Okay, next is the paraphimosis. That's also urological emergency. That is the when the foreskin of the unsucking penis is retracted, and so that's will come over other. So that's retracted and it's very painful. Vascular enlargement, edema of the distal gland. That's also very important. So it can be prevented with circumcision. So paraphase management algorithm, that's very important. Okay. So first of all, step one, you will do the manipulation. Okay. You will apply the saline soak swallow. So first you will follow this algorithm. So first of all, you will saline soak swab. You will reduce it manually compression, and manually try to manually manipulate it. Then is the puncture technique. So that's what you can give the injection of hydrolysis prior to compression reduction. And then is the surgical intervention. Perform dorsal slit procedure inside the dorsal thread. You can do the so this algorithm is also very important. Acute epiglottitis, H influenza B, we have discussed it. So that will be drooling, Strider. Okay. So Strider algorithm I have shared with you. So epiglottitis. So what will you see on the X-ray? That's very important. So they will give in the exam, they will not give this simple scenario. They will give X-ray, okay? Acute epiglottitis, X-ray. What is the other name of this disease? So you must go through epiglottitis, X-ray, okay? So here you can see in the arrow, thumbprint sign, okay? So this also you can see, thumbprint sign, you can see clear? So in the exam, they will be not clear like this thumb, okay? They will not, Arkham will not say thumbs up, go for the epiglottis. No, they will give a very confusing X-ray like this, okay? So here they like this X-ray, thumbprint sign, very important too. Okay. Short, short buffer speed, drooling at strider, that you must remember. In this, it's very important. Whenever you see that acute epiglottitis, you will call the anesthesia and ENT. Okay, so that's very important. If child is under 6 years for urgent intubation, because it will be a difficult intubation, you will call the anesthesia and ENT. Why you are calling the ENT? ENT will do the intubation. Why you are calling the ENT with anesthesia? Yeah, if failed, then we will go for the surgical airway. Okay, so that's why we are calling. Kawasaki disease we discussed, vasculitis, more than 5 days, conjunctivitis, swelling, unilateral non-fluent, cervical lymphadenopathy, HB, low platelets, WBC more than, albumin, electrolytes, that's management. We will give the intravenous immunoglobulin, aspirin, that's you must remember the aspirin, and this time we can give the steroids. So next is the child abuse, injuries, wounds, and burns. NAI, that's very important. One question is must from here. So they will give the scenarios that what the feature suggests the NAI. So that's how the question will be asked. The bruise on the medial aspect of the upper arm or thigh. Okay. As the child has accidentally touching, so it will be outside. But if anyone is trying to, that would be hit the child, that will be on medial aspect of the upper arm and thighs. Bruise and non-mobile babies. Okay, non-mobile babies, that baby is can walk and move, but if baby is having bruise and history is confusing, so that means there is something fishy there. Bruises on non-bony part of the body. Okay, face and including the eyes, ear, and buttocks. So that's uncommon injuries bilaterally. Finger imprinting like slap mark or any iron mark, any stick mark, belt mark, rod mark. So that's imprinting of anything. Sticky on the face, that reflects smoothing and asphyxiation. It was suggested that would prevent. Bruise over the knees and shin is a normal finding in children. So that's you must remember. Bruising over the knees and shin is normal finding. Bruises over the lateral aspect of their elbows in older children during play are considered as normal finding. Fractures, so falling fracture suggests NAI. Rib and spinal fracture, long bone fracture, that was a common fracture, but the age should be less than 3 years. Okay. Salter head is type 1 and type 2. Fracture who are not mobile, child who are not mobile. Head injury, suspect child, NAF child has internal energy and the absence of major trauma, non-medical cause. So that's when you were suspected child under age 3 years, lateral hemorrhage, long one, thermal injuries, mobile, burn to any soft tissue of the backs of the hands. So if child is having accidental and accidentally touching the rod, iron, anything hard, any hard thing, so it will be on the palm of the child, okay? But if it is NAI, so most likely on the back of hand. So in the exam, they will give this medial thigh, back of hand. So that's type of question they will ask. But which sign and symptom is the NAI? So that's you must remember. Scale to the buttocks, perineum, lower limb, scale to the lower gloves, emotional abuse. So that's written excellently in OHM at the last few chapters that are psychiatry and children, pediatric. That's written good. Anyone have gone through that the pediatric section of the OHM? I mentioned in. Don't worry if you're not, but you can also go through this file. So you can see the most of the pediatric question that will be from all of the syllabus SLO1, like cardiology, respiratory. So, but there are some typical questions we have discussed now. Neglect, when we will say that neglect, that's also important. Children who are living in a home that is indisputably dirty or unsafe, who are left hungry and dirty, who are left without adequate clothing, not having a winter coat, in dangerous condition around drugs, alcohol, or violence, are often angry, aggressive, and self-harm, who fail to receive basic health care, who fail to seek medical treatment when their children are ill and required. So, in management of child abuse and especially child abuse involves senior clinician, pediatrician, ED consultant. So, we should follow the protocols. We will assess the child, arrange the hospital admission for further investigation. So, we will involve the social services. Child social services, forensic examination, treat painful or life-threatening injuries. So, that's sexual abuse. Both boys and girls are affected. Abuser is often male, relative, or carer who is well known to the child. That's very important. Following features suggest child abuse, injury to the genitalia, anus, perineal pain, discharge or bleeding, behavioral disturbance, inappropriate sexual behavior, child may allege sexual abuse, STIs, pregnancy, repeated UTIs. Record the child's statement word by word, don't perform genital examination, involve senior clinician, require urgent intervention, so we should not destroy that. So that's like in Pakistan, we do the forensic examination. We will don't shower, bath, change or wash the clothes, refer urgently to a specialist. Sexual assault. Female genital mutilation, that's very important. It has been asked many times. Okay. So female genital illegal and it is a surgical operation or a girl, a woman irrespective of her age. So in this, they will give that because it is illegal in UK, so it will be a scenario that female age will be 16 to 18 years. Okay, 16 years. Okay, 15 to 16 years. Sometimes the scenario they will give a 16 years girl who was visited with her maternal uncle, with his uncle, with anyone in the Africa. And when she came back, she presented to the emergency department. She is shy, she is having urinary symptoms. So that's how they will give the question. Okay, so that will be a female genital mutilation. So that's you must remember. Arranging UK resident to be taken overseas for the purpose of female genital. It is offense for those with parental responsibility to fail to protect the girl from the risk. So confirmed under age of 16 must report to police within 1 month. Diagnostic features, patient may report history of prayer, genital instrumentation, painful period, and pain with urination. Definitive diagnosis made after physical exam. Complication can be urinary retention, genital swelling, hemorrhage. So that's can be. Sudic, unexpected death in child. That's sudden unexpected death of child. If child found collapsed in hospital, you will call the resuscitation team, ED team, call senior pediatrician, ED consultant. So that's, but if it is outside the hospital, okay, so you must call the ambulance, you must call the police. And from after when the ambulance crew will reach there, they will attempt the resuscitation, observation, find anything, then they will call the ED. So then the question they will ask you, paramedic have informed the ED that we have find a child found dead at home. What should we do? You will ask to bring the child to the ER. So that's what, when the child is in the ER, so you will inform the hospital safeguarding team that these two questions can be asked. Okay. First, ambulance crew will call you. So what you are going to say to the ambulance crew? You will ask, bring the child to the ER. Okay. So there will be many options. Declare death, make the death certificate. So that's how that they will give. And the other thing that when the child have been brought here, then you will involve the on early basis hospital safeguarding team. Postmortem required, mortuary viewing, coroner's report, shooting investigation. That's what are the notifiable diseases? I have told you, non-notifiable. Sorry, that looks like notifiable, but they are non-notifiable. Though in the exam they will ask about the non-notifiable. What the formula I told? Yeah, we will. But in the first we will call the safeguarding. Okay. If there is any suspicion, then we will involve the HGC. Always remember the HGC for non-notifiable. Although they look like HAV, look like notifiable. E, Epstein-Barr virus, C, chickenpox, but they are non-notifiable. Either they can give in the scenario these three diseases, and other they can ask which is the notifiable. So that's how it will be easy for you. Diabetic ketoacidosis we have discussed. Okay, DK I think we have done it. Any confusing thing in the DK? Dear diabetes, that you must remember more than 11 millimole. Keto means sugar more than the keto, that would be more than ketonemia. Okay, and then the acidosis, pH less than 7.3. By God, that's what you must know. If it is in shock, non-shockable, we will give the fluid, mild, moderate, and its algorithm you must follow, that's given. Initial 10 ml bolus you will give, up to 40 ml you can give. Non-shockable, that's you will give the fluid, calculate the fluid deficits, maintenance. You will start at 0.05 to 0.1 unit, but if it is a severe case, pH less than 7.1, then we will start at 0.1 unit insulin, and that's you must remember. Potassium protocol, you know all about it. Cerebral edema is a life-threatening complication decay, that you must remember. We must start the hypertonics line for cerebral edema. That's all from today. We can also discuss one quiz. Okay, so how many quiz we have discussed? 16. We will discuss 17. You must all go through these quizzes topics, not the question. Okay, quiz topics that should be on your fingertips. If I will have a time, I will also uh, give a quick overview. So the tables I have uh, shared a file, the tables file. I will give a quick overview all of these tables. Okay. So I will tell you tomorrow or day after tomorrow. But I told you that you have 4 days. You must revise all of the course in these 4 days. At least station, trauma, important topics, and then we will have a fast revision, 4, 5, 6, and 7, and then we will have a mock on 7 evening. I will give you the mock exam on the 7. It will be active for only 4 hours, and because you have to attempt it in the 4 hours. Okay, 4, and so you may, and after that you will also have the 4 days. The 40-year-old male presented to the ED with a complaint of severe painful eye associated with lacrimation, photophobia, conjunctival hyperemia, and decreased visual acuity. His corneal fluorescence image is given. So what you are expecting from this sign and symptom before going to see the option? Okay, I will share this file with you too. Okay, so keratitis, dendritic viral infection. So good. So that's the, what can be the differential for this? So that's the, you can see that is dendritic ulcer. Okay. I have shared with you this file. This file. Yeah, okay, I will share. Okay. That's the viral infection, and you will give the topical Gensi cover that because it's caused by the herpes simplex, that you must remember. So we will refer the patient to the eye department for same day assessment. That's very important. Next, 70-year-old male presented to the ED with complaint of scrotal pain, swelling associated with urethral discharge, examination, pain relief on elevation of the testes. On made, what is the most likely causative agent in this patient? Okay, so most common in UTI, and that's bronchitis, that is the E. coli. So that you must remember. But in sex-selective people, that 14 to 35, that you must remember, that can be Neisseria gonorrhea and chlamydia trachomatis. If age is between 14 to 35, that you are suspecting gonorrhea, then you will give the IM ceftriaxone or the azithromycin. Okay, so that what you must give. If that you are not suspecting, then you can give the oral doxycycline plus ciprofloxacin. If there is abscess, chronic scrotal pain, sepsis, then you will admit the patient. What is the antidote of dabigatran that we have discussed? That you know, but we can discuss the other antidote. But what we use this for? Heparin. And this is for dabigatran, or this is for vitamin K, and this for warfarin, this for palidoxime, and organophosphorus, and adenosine alpha. Adenosine alpha. So that's the death thrombin factor. Well, that's you must not remember that, Shan. So these are directly anticoagulants, okay? And you must know use it for DVT, PE, so reflexive stroke. That's the indication you must know, and antidote you must know. Contraindication, return clearance. According to clinical, you adjust the doses. Just wait for 2 minutes. Oh, sorry, I was mute for how long? Okay, I was telling I have told the indications for laparotomy. Okay. I don't know. Okay. Sorry. Where was? Okay, so I was telling if the EFOS is positive, that means we will send immediately to the for laparotomy. If it is negative, that does not rule out the need for CT scan. Okay, still CT scan is the most diagnostic authentic investigation we can do. And if it is a penetrating trauma, patient is hemodynamically unstable, then we don't need the EFOS. We can directly go for the laparotomy. Okay, next you require to perform RSI in 30-year-old traumatic patient for which neuromuscular organization dexamethasone has been used. What is the contraindication to use of dexamethasone? So why it's muscular dystrophy? Yeah, risk of hepatitis. So that's so dose you must remember dexamethasone that is 1 to 1.5 mg per kg. Other that is can cause the bradycardia, muscle pain, fasciculation, and effect. So in the exam previously that have been asked the bradycardia question, okay? Bradycardia and the option that were made. You are required to perform procedure sedation in 38-year-old female who requires propofol for shoulder dislocation. What features force deep sedation? So in the exam, it had been asked about the which agent give the deep sedation. Okay, that's propofol and moderate. What are the agent for moderate? Benzodiazepines. Okay, so and also the features. That's also very important. So deep sedation in the moderate. Purposeful response following reported are that's the for the deep sedation. Okay, so that's this table is very important. Repeated or painful stimulation that will give response, and that is purposeful response verbal or tactile stimulation, and that is unarousable. Minimal sedation, analgesic antonox, normal response to verbal communication. So in this, ventilation may not be adequate and intervention may be required. Usually CVS is maintained. General anesthesia, everything will be affected. So you must remember in minimal sedation, nothing affected, everything unaffected. So and no intervention required, adequate, usually maintained. But these clinical features are very important. Antonox that can also be given by the nurses. Okay, so that's minimal sedation and moderate, and then the deep sedation. So most of the time, level 2 moderate we give in the emergency, and for deep we can give in the level 3 and level 4 we move the patient to the OR, we give it. So you must remember. Male presented to the ED with shock. You have decided to insert central venous catheter to resuscitate the patient. After access to the internal jugular vein, how would you confirm the placement of central venous catheter? Okay, so three ways we do. We do the VBGs. Okay, we will do the X-ray. We will do the transducer wave. Check the transducer and check the pressure. It is arterial wave, venous, and then we will do the VBGs and also the X-ray for confirmation. So X-ray is very important. And for femoral, how will you confirm? How will you auscultate? I don't know. How will you auscultate the central venous catheter? Okay, for femoral, you can't do the X-ray. You can't confirm on X-ray. So how will you confirm it? So that would be from the ultrasound. Yeah, ultrasound you will do it ultrasound guided, but after for confirmation, you will do the VBGs. It is a VBG sample and also the transducer wave you will see on the wave capnography transducer. That's it's written here too. Venous blood gas can be aspirated off femoral line to ensure it is not arterial. Other thing I tell you that we will attach with the transducer to check that the transducer we use for arterial line to check the pressure. We will attach it with the femoral to check it is pressure is 0 to 20. That means it's a venous. Mail to the ED after being punched several times on its face. Which of the following complication patient will likely develop? So that's what you can see and what complication the patient can develop. Left sided blowout fracture. Sensory loss in the lower teeth, forehead numbness, numbness in the lower lip, loss of sensation and clear nasal septum, numbness over the chin. Yeah, inferior rectus muscle entrapment, and which nerve will be affected? orbital. Good. So that's the complication happen. Orbital nerve. Okay, so that you must know where it is lying. Inferior rectus muscle entrapment. I have told you already. Airdrop sign. So we will refer to the maxillofacial surgery, also involve the ophthalmologist. We'll also do the facial CT scan. Okay, well represented the area with the history of redness, foreign body sensation in the left eye. Eye image is given. What is the most likely diagnosis? So that's the common question in the exam. So that's the globe. Okay, so what will you do? You will serial test, apply for skin, CT of orbit, and then you will do the conservative management, prevent the increase in pressure. You will cover the eye shield. Okay, so consult the ophthalmology, even if CT is negative. But first of all, you will do the measures to increase the intracranial pressure. Don't measure eye pressure, rectal lid. So cover with eye shield. Anything, don't take anything that may cause pressure. We can also give the tetanus boosters if required on the basis of the tetanus guidelines. 45-year-old male presented to the ED with painful left eye, blurred vision. He is complaining of floaters associated with dull, throbbing headache. Further investigation revealed he is taking certain medication for his back pain. Examination, his eye is red and inflamed. So, what's the condition he is having? Past medical history, and what's the diagnosis? Yeah, anterior uveitis and closing spondylitis. That's good. So, which test we will do for this? Hey, which test we will do? Eyes are not so much. The risk factor, ankylosing spondylitis, juvenile arthritis, Raynaud syndrome. So sarcoidosis, that you must remember. Throbbing ache. So we will give the corticosteroid, refer to the ophthalmologist. Talbot sign. Yeah, Talbot you will check. Okay, so that's the end of today's session. I hope you have enjoyed. If anything left, I will upload for the people from a previous session. Okay, for the people who joined the crash course or the American Master. So any question you can ask in the group discussion you can do. If I will have a time, I will conduct one other 2 hour session on the tables I have shared with you all. So you can recommend your friends who are going for SBA. So our 4 days past revision course, okay, 4 to 7. We will have a mock exam on 7. Okay, any question? Anything? Either we finish it. Okay, Allah Hafiz. Thank you very much. Work hard, study, only study, 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 nothing. Eat, sleep, study. Just for next 10 days. Inshallah, you will pass.